Hello, Dr. Gary Swift. Thank you so much for talking with me today.
You're welcome, Christy.
Gary, what advice would you give to couples who are considering falling pregnant?
Christy, there's a lot of things to consider in couples who are planning a pregnancy. Probably the most important thing to confront is sometimes lifestyle habits aren't compatible with optimal fertility or conceiving and can have adverse effects on pregnancy either in the early or later stages. And probably cigarette smoking and excessive alcohol consumption are the important two to address. It's important to stop smoking before you try and conceive. It's also important to limit alcohol consumption. There are some countries who recommend that it be avoided completely. In Australia, we're perhaps a little bit liberal, but we still think that regular excessive alcohol consumption has a negative effect. So a glass of wine or champagne here and there is probably not going to have any harmful effects, but we certainly wouldn't advocate regular consumption. It's important also to make sure that general health's in optimal condition. If someone's overweight, then losing weight can improve their fertility. Regular exercise is a good idea because exercise tends to be limited once you actually are pregnant. Not always, but sometimes. It's important also for women to specifically optimise the management of any background medical conditions, particularly diabetes, renal disease, blood pressure problems. There are some medications that aren't compatible with pregnancy and they need to be adjusted or changed. And optimal health gives the best chance for optimal fertility and for a low risk and straightforward pregnancy. Pap smears need to be brought up to date for women, and immunity to conditions such as rubella, which is German measles, and chickenpox or varicella virus need to be reviewed. In an ideal world, we'd have all women who are planning pregnancy on a compatible multivitamin for 3 months before they conceived. And there are multiple brands in the Australian market, and Australia is particularly diligent in registering vitamins for use in pregnancy, so that anything that says preconception, pregnancy or breastfeeding formulas are generally safe. Not all general multivitamins are safe to use.
Okay. And when a couple has fallen pregnant, when is the right time to make an appointment to see you?
Well, a couple who are, particularly if the woman's fit and well and there are no other health issues, then we often get a urine or blood test very early on to confirm the pregnancy, and then usually about 7 to 8 weeks is the first time we can actually see the developing baby on an ultrasound machine, so we can see that a heartbeat's present to be able to reassure the women that there is an ongoing pregnancy present. There are some conditions where the women may be unwell or have bleeding or pain or be at high risk of other conditions like ectopic pregnancies, when we'd like to see them very early, so literally as soon as the pregnancy test is positive. So it's assessing the early stages. As I said, depends a little bit on background risk, but most healthy couples with no adverse features probably need a first visit around the 7 to 8 week mark.
Gary, what tests are needed throughout the pregnancy?
Pregnant women require an initial run of blood tests, and that's to check various things. It's important to know what a pregnant woman's blood group is, whether she has what's called preformed antibodies in her blood system, because they can impact on the way we manage the pregnancy. Women with negative blood groups need extra attention and a specific set of injections to protect the baby. There's a standard infection screen that is recommended by the College of Obstetricians and Gynaecologists across the country, which is standard, and that includes screening for rubella, syphilis, hepatitis B, hepatitis C, HIV, and then most of us would add in varicella, and there is also the opportunity in certain risk categories to add in other infectious screening if necessary. If particularly sort of knowing whether someone's vulnerable to infections such as rubella or chickenpox is important when you embark on pregnancy. We can't vaccinate against everything, but there are a lot of things that we can be proactive about. So they're all done often to coincide with the diagnosis of pregnancy. Then usually an early ultrasound to correctly date the pregnancy to make sure it agrees with the menstrual dates. Again, about the 6, 7, 8 week mark is ideal. Then most couples these days we would offer the first detailed scan, which is a genetic screening or Down syndrome screen called a nuchal translucency scan. And that's done between 12 and 13 weeks gestation. And that's where we measure a little clear zone over the back of the baby's neck and add that to 2 blood tests we do and the mother's age, and that gives us a risk profile for Down syndrome. That may direct other testing. Sometimes women need invasive testing, either what's called chorionic villus sampling or amniocentesis if the risk of Down syndrome or other genetic problems is elevated, and that requires much more in-depth discussion and very much on an individual basis. At 19 weeks we would then plan what's called a normal morphology scan, and that's a detailed check to make sure all the baby's organ systems are developing normally, to make sure there's no significant malformations that might affect the way we've managed that pregnancy, and particularly the timing, place, site of delivery. And then there's another series of blood tests at 28 weeks where we specifically screen women for gestational diabetes, which affects about 5% of women, slightly more common in women who are older, who are overweight and who have strong family history of diabetes. And we need to detect that condition because that also affects the way we manage them antenatally. Sometimes we have to adjust the diets, monitor blood sugar levels, all to prevent problems down the track. And unless anything else has specifically arisen, they're the standard tests we would do in a pregnancy. There are sometimes women who need further scans to check the position of the placenta, the growth of the babies, to make sure that the health and well-being of the baby is progressing the way it's supposed to. There's always a small number of babies who won't grow to their potential or grow too big, so there are issues that we need to sort of be keeping a close eye on. And that's I suppose the crux of specialist antenatal care, because specialist obstetricians are particularly trained to identify problems when there's a deviation from the normal and to talk about what interventions or what sort of management's appropriate, again, to obtain the best outcomes.
Can you outline for me what is considered to be a normal pregnancy and what could possibly go wrong?
Look, normal pregnancy, Christy, is basically when all our test results return normal, when in the absence of any disease processes in a healthy woman going through what's basically a natural process. And then in that scenario, the obstetrician literally is sort of standing by and ticking the boxes and making sure what's normal stays normal. What I would sort of consider a normal pregnancy is someone who has a low risk for Down syndrome, normal blood results at the beginning, a normal morphology scan, so there's no evidence of malformation. We've excluded gestational diabetes, we've monitored the blood pressure and sometimes urinalysis to make sure there's no toxemia or blood pressure problems. And then ideally, most women will come into labour between 39 and 41 weeks. So 40 weeks from the last normal period is the due date that we calculate, and we always check that against an ultrasound. So a normal woman has a healthy baby that's in a normal position, that's a normal size, that's going to come into labour around about a due date. What becomes abnormal then can be a series of things, and there's books on the shelves that sort of are full of things that can go wrong, but the vast majority of women are normal and healthy. Everything from increased risk of Down syndrome or genetic problems early on to problems with malformations, which 1% of pregnancies will have a major malformation, and that's the way nature works. 3% of pregnancies will have a minor malformation, and we can't always pick up all of them. A pregnancy that goes into labour, or a woman goes into labour ruptured membranes earlier than sort of 38 weeks is what we call prematurely, is going to deliver prematurely, and that becomes abnormal because we've got a baby that may behave prematurely and may not be quite ready to be born. There are some babies who don't grow to their full potential because the placenta doesn't work properly. There are some placentas that are too low in the uterus so that normal delivery is not possible and caesarean sections required. There are some babies that grow too big for the mothers, and we know that potentially a woman going to labour with a baby that's too big for her is going to either potentially cause harm to herself or have what's called an obstructed labour. And we try and predict those things. Women who tend to try and go overdue and not go into labour on their own, scenarios where we've got to either bring labour on. There's always a small percentage of babies who are in the wrong position when labour starts. 4% of babies will be breech or upside down, and it's not a safe way to be born. And obviously there are other situations, like if they're twins or multiple pregnancies or background medical conditions, which can impact on both the health and well-being of the mother and the health and well-being of the baby. So the trick then from an obstetrician's point of view is to try and monitor for abnormalities. If abnormalities do occur, it's a case of whether are they minor and they're going to impact on the health and well-being of the mother or baby, or is this something that we can stand back and sort of guide through still normal deliveries, because that's still ultimately our aim is to help healthy women have babies normally, but also important to not put babies or mothers at risk when they need help, and that's sometimes when caesarean sections are necessary.
Gary, what are the options available for delivery?
Christy, most healthy women with normal sized babies at full term will embark on a normal or vaginal delivery. Now, in this day and age, women also have the option to elect for a caesarean section if that's their preference. And in that scenario, we deal with the Caesar as an elective procedure and discuss on an individual basis the pros and cons. So a healthy woman with a normal sized baby that's in the correct position in the pelvis, we would expect her to go into labour, somewhere a week either side of a due date, and progress normally through labour. We know a small number will get stuck and need Caesars. We know a small number might need a help out at the end if the mum becomes exhausted or the baby starts to play up and not have the right reserve. But that's our ultimate goal. With specifically, when you look at elective caesarean sections, some months it's probably up to 10% of couples who say, look, I don't want to go through labour. And sometimes they need further explanation, make sure their fears are allayed. Some women have fears that aren't well founded and some need further discussion. And some scenarios where particularly mums might be too small, might have a family history of problems, might have other issues, sometimes they're often better served with caesarean sections as an elective procedure. And then it's a case of discussing exactly what happens, the pros and cons, and as again an individual discussion to make sure that the outcomes ultimately that we're aiming for, which is a healthy mother and baby, are going to suit both parties.
Is pain relief often required, and if so, what options are available?
Look, in this day and age, there are probably more options available to women than there ever has been. There are still women who come in and manage to labour well and deliver their babies with not so much as a Panadol, and obviously that's the ideal scenario for healthy women to not need any drugs or medicines. Some women use hypnobirthing and other techniques to sort of help them cope with the discomfort or pain of labour. But women who do find that the pain associated with labour is overwhelming can have anything from TENS or transcutaneous nerve stimulators, which are non-pharmacological, to injections of narcotics if they need them. There is nitrous oxide gas, which often helps women during the pain of contractions. And of course, the top of the scale is the epidural, which is where a very small needle is inserted just outside the spine to numb the nerves that basically are sensing the pain from the uterine contractions and delivery. It's very much an individualised. We certainly don't push anything on anyone. We listen to the women and what they need. We try very hard to educate women in advance what their options are, because in labour is probably not the best time to sort of sit down and try and discuss the pros and cons of things. So basically we have a wide range of options, and we try and tailor that individually to what women need.